My project title is 3-year experience with the JRI reverse shoulder replacement. According to the literature, the first popular and recognized indication for the reverse shoulder is to treat patients with rotator cuff tear arthropathy. And since the indications have expanded and surgeons start to publish studies using this technique to treat another conditions, such as proximal humeral fractures or massive rotator cuff tears without glenohumeral arthritis, revision arthroplasty, and glenohumeral arthritis with irreparable rotator cuff tears. With more indications, new designs start to be needed, and in order to improve survivorship, rate of complication, and postoperative function. And many new models started to be introduced in the market, but only limited follow-up has been reported so far. This is the JRI reverse shoulder implant, which is used here in Ninewells, and it was released in 2010. Our aim was to analyze then the short and medium-term outcomes of the JRI reverse shoulder, of the patients that received the JRI reverse shoulder, and also to compare the operative results of the patients treated for proximal humeral fractures with those treated for rotator cuff tear arthropathy. To be included, the patients must have undergone a surgery, a reverse shoulder replacement, and received the JRI reverse shoulder. And the study was divided in two phases, a retrospective case review and a review clinic appointment with applications of validated questionnaires, such as the Constant-Murley outcome score, the Oxford shoulder score, and a quick version of the DASH score. One patient had to be excluded from the study because he passed away in 2012, so we invited 20 patients by letter, and 11 confirmed and attended the appointment. And we decided to divide these patients into groups. One group with 7 patients treated for cuff tear arthropathy, and another group with 4 patients treated for proximal humeral fracture. In Table 1, we have the demographic data of all the 11 patients with a mean age of 70.81 years, 6 males, 5 females, 5 right shoulders, and 6 left shoulders operated. The mean follow-up was 15.83 months, and we found 2 complications, 1 infection and 1 periprosthetic fracture. Here in Table 2 and 3, we have one of the parts of the Constant-Murley shoulder score, which is the subjective part, with which the patients answer in the questionnaires, and they can graduate their pain in none, mild, severe, or moderate. And we can see that in Group 1, all the patients had improvement in pain, and in Group 2, 2 patients had no change in pain before and after the surgery. Here we have the scores in a graph comparing the 2 groups, and we can see that the Group 1 with treated for cuff tear arthropathy had better and higher results than Group 2 in all the 3 questionnaires, Oxford shoulder and the quick dash. Here I decided to put just the objective part of the Constant-Murley to illustrate a little bit of the range of movement and the strength of these shoulders. And also we can see that all the values are higher in Group 1. To start the discussion, it's important to clarify the limitations of the study, such as the small sample of patients. It's part retrospective. I found lack of information in the files in medical records. Only 55% of the patients attended the review clinic appointment, and also we didn't use updated X-rays as part of the study in the review clinic. So statistical significance was not reached. Further investigation is needed, but we found that it is still important to share the experience with the JRI reverse shoulder so far in Ninewells Hospital. So regarding pain, I just said that 9 patients had improvement in pain and 2 patients had no change. Some studies show us that more than 90% of shoulders had no or minimal pain at follow-up, and constant scores improvements were noted. Reverse shoulder is known for alleviate the pain better than other kind of replacements. Rate of complications regarding the procedure in our study was 18.2%, and Zumstein, a big meta-analysis, found that complication and revision rates could go from 15 to 50%, and infection rates from 1 to 15%, which is 4 times that of total shoulder arthroplasties. In our study, we didn't find scapular notching or failures so far. Group 1, as I told, you had better results than group 2. And first of all, we decided to divide these two groups because in the literature we can see that the results of reverse shoulders always depend on the etiology. So we decided to compare these two groups. And Kazanov, in a study just with 3 and 4 proximal humeral fractures, found that reverse shoulders had good results for pain, disappointing for strength and mobility. And that can try to be explained with the patient's expectations, because when treated for cuff arthropathy, the patients have osteoarthritis, which is a chronic disease, and they have a bad shoulder for several years. And when they receive a replacement, they are more they can perceive the improvement better. And in fractures, the patients had a good shoulder, and it fractures, and now he has a shoulder with limitations that he didn't until now. So to conclude, we found that satisfactory functional scores at short and medium terms. Also, we found outcomes comparable to the literature for cuff arthropathy, and patients treated for proximal humeral fracture had clinically poorer results than those treated for cuff arthropathy. And also, this study can be used as a summary of the reverse shoulder replacements in INLs so far. I also would like to suggest that this study should continue prospectively, and it would be good if 9-wells adopt as a routine for these patients to use this 3 scoring system pre and post-operatively. And also, we could have used updated X-ray in the review clinic to see if there's scapular notching or failures or... Thank you.
Thank you. Then I have here, Bruno, for you. Why did you not use the 20 that you had for the demographic part of the study?
I used. Actually, the demographic part is about 11 patients. This part. This
yeah, that's what I'm saying. I mean, how many operations of the 20? How many were males, females, and things like that? Did you find any complications in the notes of the? Because you're missing half of your patients are not there.
Yeah.
But you could have gone into the notes. Did you look at the notes of the 20 patients?
Yeah, I looked.
Have you
I have all the information. Yeah, just when I discarded the patients because they didn't attend the appointment.
But, I understand. You obviously you cannot say. You cannot report an interview that you didn't do.
Yeah.
But you could say, well, of the 20 patients reported in the notes, there were, say, infection would be reported there. So the rate of infection we could have out of 20 rather than out of 11.
Yeah, that's true.
Do you know how many infections were there for the 20?
No, just one. 20 patients, just that.
Just one out of the whole 20, okay, so that's not too bad. Yeah, and the other thing is that there are some issues which you might have commented on. Do you think that 2 that did not improve pain, how does that relate to with the literature that says a 90%, because 2 out of 10 would be 80%, isn't it?
Yeah.
So what do you think? Do you think that this is because you're not operating as well as the others, or how would you explain that?
Actually, that 90% of pain improvement is just about cuff arthropathy. They are not. They do not include the fracture patients. Right. In this study this Kazanov study, just for fractures, they found good results for pain, but not as in my study, we found good results for pain in both groups. We can say, but in group 1,
2 it would be 50% if you. But even if you take the whole group, you would still be 80%. So
yeah. But it's difficult to say something based on 4 patients, I think. But yeah, it's in the literature we can see that pain for cuff arthropathy is better than fractures.
Okay, thank you very much. We'll discuss that more in the back, I guess. Graham, do you want anything?
Can you just move forward a couple of slides?
Which one?
Yeah, that one. Ignorance here, but is a high score good or bad?
The high score is good.
Okay.
Yeah.
The higher the better.
Yeah, higher the better. Yeah, I wasn't quite sure.
Just in the dash, it's the other way around, but I adapt.
said you reversed
yeah,
it.
I reversed it to compare better.
Could you ever get 120%?
No, the 100 is the best.
Okay.
Okay?